Hello, everyone, and welcome back to the Intent Medical Group podcast, where medicine meets mission. I'm Dr. Sammy Khalili, and I'll be your guide as we explore the stories, breakthroughs, and people behind exceptional care across our team and others. If you're new here, we're so glad you're joining us. And if you're returning, welcome back. I am super excited here today to come talk to you guys with one of our amazing spine surgeons, Dr. Azeem Rehman, who is here to kind of talk to us about his journey into medicine, but not only that, teach us something about spines. So let's get into it.
Well, thanks a lot for having me. I really appreciate it. You know, there have been a couple times where we've tried to arrange this and our schedules always conflicted a little bit, or some emergent case of happened.
That's truly the nature of surgery, isn't it? I mean, like, even trying to get over here just right now, we almost couldn't make it because another thing came up and whatnot because of the OR or whatever. But that's the nature of what we do, I suppose.
Yeah. No, I'm glad we're able to coordinate a time and get it set up. And I appreciate all the time and effort that you and Yasmina have made to really get this podcast kickstarted. So I think it's a great thing for us to kind of share what we do to the local community as well as nationally, and give insight into all the kind of remarkable things that are being done here at a Northwest Community Hospital.
Well, thanks so much for your kind words, buddy. It's because of people like you and all the work that you guys are doing that allows us to give us this platform to discuss and share with everybody. Yeah. And we knew how quality and good you were, that we did everything humanly possible to said no matter what, we would make this happen. I know that Yasmina 100% agrees. She doesn't have the mic on her right now, but she's nodding there in the background. So, yeah, no, I think the best thing for a lot of people to know about yourself is just, I want you to take me into when you first decided, not even talking about neurosurgery or spine surgery or any part of it, when was it that you decided that you wanted to go into medicine and not do something else? Because so many of us, like, you know, there's a lot of other things that you might have been interested in, the other career paths you could have taken. But
I had an early exposure to medicine through my father. My dad he still is a family physician who works in a rural part of the community just outside of Peoria, Illinois. He works in a small town called Chillicothe. Yeah, he's still in his now getting to his mid-70s and still practices as a family physician in the community there. So I was able to get some early exposure to the field. But with that said,
you just, not to even interrupt you, but you grew up outside in that area, like in where he's been working, or did you guys move somewhere else?
Correct. No, I grew up in Peoria, Illinois.
Right.
Yeah.
Okay.
So I've been there pretty much outside of my residency. So from primary school, middle school, high school, college, medical school, I was in Peoria, Illinois. So all of my education and personal life is there.
What's interesting, just to kind of go back to that for a second, is that I was just having a conversation with a couple friends there yesterday. It was at my kid's soccer game, and a lot of them had grown up in small towns, and each one of them, their expression for it was that they didn't enjoy it because they felt like everyone knew their business, particularly when one of them was the physician or whatnot. Now, I grew up on an island, and a lot of the audience knows this, and I love that because everyone knows each other. How did you feel about that growing up, because I'm sure there weren't too many physicians in the town that you were in, right?
Yeah, no, I mean, I really enjoyed it. I mean, a lot of my childhood friends I kind of kept through my advanced years going into high school and college. I would say the town is still large enough where if you went to like a supermarket or the mall, that you may see like a couple people here and there that you know, but at the same time, it wasn't like overwhelming where every single person you saw was someone new, because it was still kind of large enough where you still kind of had your own personal life. So.
Cool. Okay.
But I liked it. I mean, in retrospect now, it's been kind of stagnant. Like it hasn't really grown very much. There have been a lot of changes. I mean, for example, the headquarters for Caterpillar used to be there.
Okay.
And now it moved to, I think, Deerfield.
Right on.
So there have been some changes in the employment opportunities in Peoria. So it hasn't really been much of a growing city lately. So I don't know if I'd like to live there like now during my current time in life. But it was a great place to grow up, a nice kind of small town and good community, good place to raise a family.
That's awesome. So after all that, you're there. You have a great group of friends. Sounds like a wonderful family environment, and your exposure to your dad. At any point, was it just a natural feeling that you wanted to kind of follow in his realm, or did you want to do something different?
Well, I had a lot of different interests growing up, like I was interested in a lot of different things. I liked all the subjects in school, not just science. I liked, creative writing and reading and language arts and history. So there wasn't any particular field that I really gravitated towards. But when I was getting into college, and having to decide on a major, I really wanted to be somewhat focused in my college studies. I wanted to do something that I felt would at least get me set up to embark on my next career path, whatever that may be. And because I had a lot of diversified interests, it was a little hard to decide what I think I would like to do. But in talking to my dad and in talking to some friends and in talking to my older siblings who also happened to be in medicine, the general idea I got was that, in medicine, there's just so much diversity. There's just so much that you have to offer. And at the end of the day, you're going to be helping people. So I felt that, if I embarked on a career in medicine, I could find some particular field that I would gravitate towards that would really spark my interest. And at the end of the day, if you were working towards helping someone, I thought it would be a great career path. So that's kind of how I thought about it. Like, it kind of gave me an opportunity to pursue something where I would be helping someone, but at the same time, I didn't have to necessarily definitively decide on what specifically I would be doing, and that a career as a physician would offer me a chance of exploring different pathways.
Yeah, I mean, that's one of the beautiful things about medicine itself as a career path is that you can be a physician, but you can do so many things at the same time as part of it. Yeah. So many of your colleagues, my colleagues, are artists, they're musicians, they are engineers. They have a whole array of other things that they're also involved in. Some of them are business owners because they, not just from their medical side of things, but that's a muscle they like to flex. I'm in complete agreement with you that for all young people out there, I highly recommend this career because it opens up a tremendous amount of choices for a person, even though it might feel like you're locking yourself into one thing.
Yeah, and I don't know why there is a sentiment that's often propagated by physicians that this is like a bad career, that they wouldn't want their kids to do it. And I really am not of that attitude. I find my career to be incredibly rewarding. Obviously, there are challenges and hurdles that you have to overcome in terms of billing and paperwork and whatnot and taking call and all that. But at the same time, I really am happy with the career that I do. And it's one of the things where I feel like each and every day I wake up and I tell myself, as long as I feel like I'm making the right decision to help someone, then I'm doing the right thing. So I think there are very kind of few careers like that where it's so oriented on just doing the right thing for the person.
I 1,000% agree with you. And it's a very satisfying feeling to know that, like, a lot of things you don't necessarily know if you're doing them right, making the right decisions or whatnot. A lot of my friends who work in government or things like this, they're just, they're moving in and moving out, doing what they are being told to do or whatever the agenda or the mandate is. But for us, we've been taught to kind of believe in a specific way that, certain things we believe them to be the correct pathway forward, and or not even necessarily the correct pathway forward, but what are the best options for the patient, and we help guide them to choose what is best for them. I think that's what a lot of the work you do, particularly, goes into that ilk.
Yeah.
So now you're in medicine. You get to that point. Where'd you go for medical school?
So I went to the University of Illinois for medical school. The University of Illinois, when I was applying, and still actually to some degree, this is how it is today, but they have multiple campuses, So the main campus is in Chicago, but they also have a campus in Urbana-Champaign. They have one in Peoria. They have one in Rockford. So I spent 1 year at the Urbana-Champaign campus, and then after that first year, for the remainder of my 3 years, I was back in Peoria, Illinois. So I went to University of Illinois for medical school. I actually lived at home during medical school. So
that's awesome.
So yeah, interesting experience, going, because I also lived at home even during college, so I was at home for some time. But I had that one rebellious year, I guess, in Urbana-Champaign during my first year. But it was a great school. I really enjoyed it and really enjoyed the faculty and all the students around me. There was even a student that I was with who I had gone to college and high school and middle school with. So, and I also had a lot of friends in the area. My family was in the area. So I had a very strong support system, both from a family and friend perspective.
That's fantastic. So then now you're in medical school, and it sounds like you're very similar to how I was. There's a lot of choices you could have made. You probably would have been happy with many of them.
Yeah, no, yeah, that's true. I wasn't one of those people who from like day one was like, oh, I'm going to do surgery or neurosurgery or anything like that. I kept a very open mind about things, had a lot of diverse interests. As I thought about it more, I just kind of thought about the career I wanted. I wanted one where I interacted with patients. So obviously there are certain medical specialties where you don't really have to interact as much with patients. So that kind of ruled out some fields. I like the procedural aspect of surgery. So whether that be ENT or general surgery or neurosurgery, I like the surgical fields for a couple reasons. One is that it does kind of provide some diversity to your overall work life. So it kind of keeps things interesting. But I am sort of like a very detail-oriented person. And so at least whenever I do cases or do surgeries, I try to think about, well, how can I do this better? Like, what are some ways or techniques that I can do to make myself safer, more efficient, more effective? And each and every time I do a surgery or procedure, I feel like I learn something new. And I like that aspect of sort of doing something, reflecting on what you did, and the next time you do it, doing it even better than before. And so I felt that the surgical fields really kind of offered that opportunity, and it was something I really thought I would enjoy about the field. And then beyond that, it's some more nuanced stuff. So do you want to deal with macro surgical stuff? Do you want to deal with more microsurgical things? Do you want to deal with kids, or do you want to deal with adults, or adults and kids? And I also thought about it from a more academic research perspective as well. I was always interested in research, and I felt that the neurosciences as a whole were like a very research heavy field. And that's kind of how I gravitated towards neurosurgery. And I think similar to a lot of other people, you meet mentors or meet people who are in the field, and you kind of see kind of yourself in them. You kind of reflect and look at them and be like, oh, that person kind of has the same personality as me, or kind of has the or is kind of very successful in their field, and it kind of motivates you or pushes you to, become interested in that. And so a lot of it also has to do with just the mentors I worked with, and the early research opportunities I had as well. When I was, thinking about, the different residencies and the different fields available, I kind of sought out research opportunities. And it just so happened that one of the neurosurgery fellows where I was doing my school in Peoria kind of reached out and kind of got me involved. So that was just so happened to be that he was in neurosurgery, and that kind of piqued my early interest. But again, not one of those things where I was gung-ho from the start to do a particular field. There was more so just the exposure I had, the experiences that I had, the people I met, and then in reflecting kind of the interests that I thought were in line with the field.
That's awesome. So you made the decision, and I know you went to a phenomenal school. You went to Rush for your residency. Fellowship. Okay, yeah. So where'd you do residency first?
So I did my residency in West Virginia.
Oh, no way.
So first time really leaving from being home. I went all the way to West Virginia. So I was there for 7 years.
My oldest friend in life, my oldest friend that I've known since she was 3 years old. She moved to West Virginia. I don't know the name of the town that she's there, but they love it. They're really, really happy out there. Sounds like good people.
No, great people, great experience, and met some great co-residents and faculty that I still talk to this day, and really learned a lot. Have nothing but positive things to say about my experience training there, but also the hospital as a whole and the community, both within the city of Morgantown,
Okay.
which is where I was, but also as a state as a whole, just very kind, nice people. And then, so after West Virginia, I went to Rush in Chicago and did a dedicated 1-year fellowship in spine.
So now, tell me about what led you to that, because neurosurgery has a variety of things you have options for. You can go into cranial, you can go into epilepsy, you can do other things, peripheral nerve things,
Yeah, there were a lot of factors at play that kind of drove that fellowship experience. One factor is I like talking to patients. And so, not to say you don't talk to patients in the other neurosurgical fields. I mean, of course you do. But especially in spine, it can be a bit of a mystery sometimes because everyone develops arthritis in their back. Just like you develop arthritis in the knees and in the hips, you develop arthritis in the neck, upper back, and lower back. And often what happens is a patient sees their primary care doctor and they have complaints of neck pain or back pain or arm pain or leg pain. And then they get the imaging, and the imaging, when you read the report, has all these findings. And it's hard for anyone to really interpret, well, what do these findings actually mean? And like I said, you will always have findings because everyone develops arthritis in their spine. So really, when you're talking about a spine surgeon, the key is in the clinic. When you talk to the patient, hear their story, try to come up with whether or not the structural abnormalities that you see on the imaging correspond to what their MRI shows or correspond to what their story is. And I think compared to a lot of the other subspecialty fields within neurosurgery, that's like the most important, is that you're really not only treating what the picture is showing, but you're really taking into account what the person is experiencing. So I really like that connection between the radiographic images and what the patient story is. Just beyond that, I like, biomechanics and material science. So there is that at play, but it's more so just sort of the patient story and relating the patient story to what the radiographs show.
That's awesome. So then that's kind of what led you to go into spine. Then you went to Rush.
Yep. Yeah.
And I'm sure you had a great experience there.
Yep, absolutely. Yeah, no, Rush was a fantastic experience. It's thought of as being one of the premier spine programs in the nation. They have a lot of faculty that are leaders within the spine field. So it was a great pleasure and honor to train there.
Awesome.
And it was also nice because I got married during my residency, and it wasn't until fellowship that my wife and I actually started to live together permanently.
Right.
So because she was doing her schooling here in the city of Chicago. So it was an all around fantastic experience, not only for my professional life, but obviously also for my personal life.
Well, yeah, it sounds like a lot of things were culminating together at that exact moment. Like now you get to live with your favorite person all the time. And then on top of that, you're doing your favorite thing all the time in a city that's really cool. So
yeah.
At least I think Chicago's cool. Some people might not agree, but
no, every step of the way, it's just gotten better and better.
That's awesome.
I've been lucky enough where every time I've gone from high school, then the college, then the medical school, then the residency, then the fellowship, and now my professional life as an attending, each step of the way has had its great memories, great relationships. But as I reflect on it, I couldn't be happier than where I am now. So.
Oh, well, we couldn't be happier, more than happy to have you. It's been an absolute blessing to have you. No one sings your praises more than your partner, Dr. Knuckles.
Oh, yeah.
Russ is he loves you, and for many people who don't know, and you will meet him at some point, he is one of the world leaders in deformity.
Yep.
And so you have been a compliment like two peas in a pod.
Yeah. No, it's really him that kind of got me interested in the opportunity that I'm in now. I mean, the reason that we had gotten connected was because one of my mentors at Rush knew Dr. Knuckles and was familiar with him because Dr. Knuckles was at one of the Chicago programs for some time. And so they had a strong relationship, strong connection. And he knew that Dr. Knuckles had recently sort of explored a new career opportunity and was looking to hire a partner. And as you know, when you start out as a new surgeon, it's just absolutely critical you have a good mentor. I mean, there's just so much out there that you don't see as a resident. And there's always times or circumstances where you have challenging cases where you need someone to help you and assist you. And that was kind of my main goal and purpose in seeking my first job opportunity outside of training, was that I needed a good mentor, someone that could be there for me to not only review cases that were challenging, but also in times of being in the OR when I needed some assistance or needed some help, would be more than willing and readily available to help me. And he has just gone above and beyond to provide that for me. So it's been
That's excellent.
Yeah, so it's been absolutely incredible to work with him. Just even beyond all his experience and training and what knowledge he has to give me, but just the support system that he offers for me has really made what would often, I think, be a challenging transition from training to being an attending. It's made it very, very seamless. So I've been nothing but positive things to say about him, and thanks to give him for the opportunity.
Well, I'm sure he feels very much the same way for you, but I'll let him tell us when the next time I have him on here on the podcast. All right. So let's talk about, Azeem, your passion, which is spines. And I think the community here will be very interested to know, because so many people suffer with back issues.
Yeah.
Guide us through how is what should be a normal journey to figuring out what is going on with your back or your spine, what they should expect in an office, what kinds of questions are important for them to ask, that kind of thing.
Yeah. So I think it's important to first note or mention that the majority of people that I see in my clinic, and again, I'm a neurosurgeon or a spine surgeon, but the majority of people I see in my clinic, I end up not recommending surgery, or they don't pursue surgery. Okay. So that's, I think, an important thing to note. So just because your primary care doctor recommends you see a spine surgeon doesn't necessarily mean you need spine surgery. And actually, it's the exact opposite, where the majority do not. So I think that's one thing to keep in mind. And
that's important for people to know, that they shouldn't go into a surgeon's office expecting that they're going to get surgery. A thoughtful surgeon should, like yourself, would be thinking about the reasons as to why the proper diagnosis would be, correct?
Correct. Yeah. And I like to use it as an opportunity to give the patient as much knowledge and resources to understand what their condition is, what type of symptoms they're having, what the images show, and what I think is maybe causing their symptoms. And I kind of layer it by saying that it's often very complicated. You know, sometimes we like to think that the solution is very simple, but in all likelihood, especially as people are getting older and older, there may be some more complexity to it. So for example, a common symptom that people come in with is back pain, you know, so that's a very common symptom that people experience. Well, to be honest, there are actually very few medical conditions where we consider surgery just for patients who have back pain. And part of the reason behind that is back pain is incredibly complex. Even though it's a common symptom, there is a lot that contributes to patients having back pain. So one example is just the arthritis in the spine. As you develop arthritis in the spine, one of the early signs and symptoms of arthritis is the degeneration in the discs. Okay. So the discs are thought about as being sort of the cushions in the spine that offset the forces of the spine, especially as you stand and walk around.
So when you're talking about discs, you're talking about the little pieces of cushions in between the vertebrae throughout.
Correct.
Yes.
Yeah. So as those discs degenerate, they lose their function to serve as a cushion. As they lose their function to serve as a cushion, the spine is still there. Like, the spine hasn't gone anywhere, but you still have to support the spine. So because the discs can no longer assume that role as well, other elements of the spine start to assume that role. So the muscles, the ligaments, the joints, and so you start to get a lot of other aches and pains because of the early arthritic process.
Mm-hmm.
That's why we often talk about physical therapy as being so important, because the physical therapy strengthens the core muscles, it strengthens the back muscles, so that the muscles and the ligaments that are now having to take up some of the load have the strength to do that.
Mm-hmm.
But we know even beyond that, even beyond looking at arthritis, we know that there are a lot of other factors at play that contribute to back pain. So the diet that someone has, the sleep that someone has, the routine exercise regimen, limiting stress in your life. All of these are factors that independently play a role in whether or not people experience back pain or neck pain. So there's a whole psychosocial lifestyle aspect to it that is also, if not equal, greater than just the arthritis that you see in the spine.
So that's interesting. You're talking about the arthritic process, and most people, I think, like myself, would think of arthritis mainly happening on the bone.
Mm-hmm.
But you're saying it does also occur within those cushion pads. So I guess my question then is, what are they changing into? What do they become?
Well, the natural tendency of the body, as the body is getting older, is that it loses some element of motion. Okay. So the arthritis is occurring at areas where there is motion. Okay. So as those things occur, as the discs degenerate, as the joints overgrow, as the ligaments overgrow, it reduces motion in the body. And so that reduction in the motion is what the body is trying to do to compensate for the aches and pains that it's experiencing.
So are there things that people can do to mitigate some of that motion change that can happen over time? Or is it something that it's just going to happen?
Yeah, it honestly depends on what areas of the spine you are looking at. So for example, in the neck, the neck is primarily there to support the head. Okay, there's very little that people actually do to affect the arthritic process in their neck. Oftentimes, even when they think they are holding things or working out in certain ways, they're often just like working out their shoulders or their upper back rather than the neck itself. So the only main thing when it comes to arthritis in the neck beyond just genetics is smoking. We know that smoking accelerates arthritis in the neck. And there are also certain autoimmune conditions, such as rheumatoid arthritis, which can also accelerate arthritis in the neck. So beyond certain medical conditions and beyond smoking, a lot of the arthritis that we see in the neck is often just related to just genetics. Now, there are certain unique circumstances, like if someone is involved in a trauma or if someone has had radiation to that area, then that can certainly affect it. But for the most part, there's not a whole lot you can do to affect the natural course of the arthritic process in the neck. In the low back, that's a little different because there are a lot of different things that people can do from a lifting perspective that can abnormally place excessive strain on the low back. And in general, and this is a common question I get all the time, is about safety in terms of lifting and good habits with lifting. And what I essentially tell people is, you should always lift in such a way that you maintain a neutral spine. So patients ask me all the time, well, how much weight can I lift in the gym? And my answer to that is you should not lift more weight to the point that you have to contort your spine to get the weight up. So you shouldn't really lift to be a power lifter.
That's a good piece of advice.
Yeah, you shouldn't really lift to be a power lifter. You should lift to kind of be like a bodybuilder. Like you want to stimulate the muscle and grow the muscle, but you don't want to lift to just get the weight up. And so as long as you can move the weight without having to contort your spine, then that should be a fairly safe exercise to do.
So
and then,
to that effect, when you say contort it, you mean either twist it to the sides more than anything else,
you should
right?
always maintain a neutral spinal alignment
Which would be
whenever you're lifting.
straight up and down.
Straight up and down.
Okay.
Yes.
Okay.
So yeah, and then in general, you know, in terms of general lifting habits, I always tell people that you should hold objects with two hands rather than one. You should keep objects close to your core rather than further away. And similarly, when lifting objects, you shouldn't be contorting your spine either. And you should avoid, if you can avoid it, you should avoid bending down to pick up objects. You should try to squat down to pick up objects. Now, sometimes it's inevitable and you have to do it to some degree because sometimes you have limitations and flexibility. But for the most part, you should kind of keep those things in mind. And I think those are kind of the main things from a day-to-day perspective that people can do to help with this issue.
That's great. Okay. Great piece of advice.
But it's inevitable. You know, like I said, just like people develop arthritis elsewhere in the body, inevitably people will develop arthritis in the spine. And sometimes people are just predisposed to it. Just like there are people who have heart attacks at a young age or a stroke at a young age or cancer at a young age. Some people are more prone to developing arthritis in their spine. So the other factor at play that's also relevant is osteoporosis, you know, and especially as people are getting older, we often like to think that osteoporosis is just at risk for postmenopausal women.
And so for people that don't know, osteoporosis essentially is just the weakening of the bone with time.
Correct.
Or hormones or whatever may have you, or it loses its bone mineral density, correct?
Correct. Yeah. Osteoporosis is a medical condition where the density of the bone decreases.
Okay.
And then it puts people at risk for getting fractures, you know, but it also puts people at risk for developing issues related to the spine. And that's where things like scoliosis can develop, for example, or people can get fractures in the spine as a result. And we know that postmenopausal women are at risk for osteoporosis, but even beyond postmenopausal women, one of the other risk factors related to osteoporosis is just aging and getting older. So keeping up with the DEXA scans, which are the x-rays that are done to screen for osteoporosis, but getting routine DEXA scans every couple years, making sure you're not getting osteoporosis. If you are getting osteoporosis, getting appropriate treatment for the osteoporosis is also very critical. What I often tell people is think about osteoporosis like high blood pressure or high cholesterol, where you don't really feel like you're having a problem until you have a big problem. So like in the setting of high cholesterol or high blood pressure, you don't really feel like you have those issues until you get a heart attack or a stroke. And similarly for osteoporosis, you don't really feel like it's a problem until you get like a fracture and then you're in severe pain.
That's right. Yeah.
So those are all also preventative things that can really play a large role in someone's overall, not only general health, but also in their spine health as well.
So is there anything that they can take on a regular basis that might be helpful for this kind of stuff? Or is there some other kind of activity they should be doing to minimize the trajectory of osteoporosis over time?
Well, specifically for osteoporosis, a lot of people take vitamin D and calcium. The studies show that with vitamin D and calcium, they are only effective if you have low levels of vitamin D and calcium. So if you have normal levels of vitamin D and calcium, it doesn't help you anymore to take beyond the normal range. Smoking, as I mentioned, for the arthritis in the neck, we also know smoking leads to osteoporosis. Otherwise, in terms of lifestyle activity, weight-bearing exercises also play a role. So it's not just about like swimming, you know, or even like running to some degree, but you also have to do some weight-based exercises to load the bone. There's like a common understanding in orthopedics that as you put weight on bone, bone grows in response to it. So you actually have to put weight on the bone in order to have the bone respond by forming new bone. So to do that, you have to do weight-based training. Beyond the calcium, vitamin D, weight-based training, and smoking, unfortunately, some people can still develop osteoporosis. And then you get into some medications like what are called the bisphosphonates, like Fosfamax or Reclast. But then even beyond that, there are actually more potent medications that work via hormonal pathways that are even more effective. And they're actually very well tolerated. And these are medications that have just started to come on the market over the past 15 years or so. So there have been a lot of advances in the treatment of osteoporosis.
Do those medications reverse the process of osteoporosis or not really?
Typically they do not, but they typically at least halt the process. One of the criticisms of these medications is that once you stop them, the osteoporosis will then continue to progress. So you often have to stay on these medications long term. But with that said, a lot of these medications, like for example, one of the medications is called denosumab or Prolia. That is a medication that's administered every 6 months via an injection. So they're not necessarily medications where you have to take a pill every day. And like I said, they're for the most part very well tolerated. But yes, they do have some limitations in the sense that they provide some reversal, but not complete reversal. And like I said, the other factor at play is once you stop taking them, then the osteoporosis then can continue to progress, unfortunately.
Okay.
Yeah.
Yeah, no, there's a lot of my patients who come in on bisphosphonates. Usually they tend to be a little bit older, and the one common one, like you said, is Fosamax. I know that for osteoporosis, for so many people, particularly in women post-menopause, it's a big thing that they always kind of are watching for. And something we're always watching for as well from our parathyroid patients when they come in, which, as you know, Dr. Mondi is the one who kind of handles a lot of those. But, all right, so now you kind of talked a lot about the trajectory of what the bone is doing, like what the process of the spine is doing as we get a little bit older. Talked a little bit about the arthritis to it. What happens with the cushions, as we call them, or the discs. Once you kind of have eliminated the other supporting mechanisms that are happening, at what point do you say, nope, this is a moment that I have to intervene and help with this person's spine in some way? I'm assuming it's not only when there's deformity, when there's physical.
Right. Now, there are certain disease processes where we sometimes recommend surgery earlier rather than later. So one example is spinal cord compression. Okay. So one of the first things we want to rule out whenever we meet with someone or talk to someone is whether or not they have any symptoms or signs of spinal cord compression. So spinal cord compression is not a issue that causes pain. It's an issue that causes dysfunction and weakness. So oftentimes
that's important to know. So
right.
So there is no pain technically with spinal.
Typically not.
Typically not.
No.
I mean, I guess it can happen, but
well, it's the reason why the spinal cord compression occurs is due to arthritis. Okay, so it's from a degenerative arthritic process. The degenerative arthritic process, kind of like what we talked about earlier, includes degeneration of discs, overloading of joints, overloading of the muscles. So that process as a whole can cause pain. Okay. And that process as a whole can also cause nerve compression, which can also cause pain. Now, it's important to differentiate the spinal cord from the nerves. The spinal cord, if you want to think about it, is sort of that thick wire running up and down the center, connecting directly to the
right in your spine,
connecting to the brain. The nerves are the wires coming off of that thick wire. So patients can have spinal cord compression. They can have individual nerve compression. They can have one or the other, or they can have both. And typically when patients have nerve compression, the majority of them get better with time and with physical therapy and injections and so on. When patients have spinal cord compression, they do not get better with anything other than potentially surgery. So in the setting of spinal cord compression, whether it be in the neck or in the upper back, those are circumstances that when we see signs and symptoms of spinal cord compression and we see imaging to support that the spinal cord is being pushed on, that we often recommend surgery earlier rather than later. And like I said, strictly spinal cord compression does not typically manifest as pain. It manifests as weakness and dysfunction. So in the setting of the neck having spinal cord compression, people get constant numbness and tingling in the hands and in the feet. They get difficulty using their hands, like fine movements of the hands. So buttoning buttons, using their keys, feeding themselves. And then they also get trouble walking due to feeling off balance. In the setting of spinal cord.
So I guess that could be confused with other things, like either if they hadn't noticed it before, symptoms of a stroke, maybe
yes.
Parkinson's, things like this, right?
Yeah, yeah, that is true. That is true, and that is a good point. You know, part of it is you have to tease it all together. Like for example, you know, I recently saw a patient who had severe spinal cord compression in their neck. And they had presented originally with dizziness, okay, to the hospital. And because of their dizziness, they felt off balance. And then they did a whole workup with their brain and their neck. And they found that they had this spinal cord compression, but they also found that they had a stroke in the cerebellum. Okay, the cerebellum is the bottom part of the brain that is involved with coordinating a lot of movements.
Fine motor movements, right?
Yeah. And so... And the cerebellum and the stroke in the cerebellum can also cause dizziness. So he also had imbalance with walking, but his imbalance over the past couple months has been getting better because his recovery from the stroke has been improving. If you have imbalance due to spinal cord compression, it doesn't usually get better. It usually just stays the same and eventually gets worse and worse and worse. So when I saw him and he was like, oh, my trouble with walking is improving, well, his trouble with walking is probably more so related to his stroke event, not the spinal cord compression that we see. So in that circumstance, it's a situation where we see imaging that shows that the spinal cord does have some compression, but at the same time, the person that I'm seeing is likely not really experiencing any symptoms quite yet.
Because of it, okay.
Because of that. And usually in that circumstance, we just recommend watching for the symptoms. So it's one of those things where we kind of educate patients about what symptoms they need to look out for: numbness and tingling in the hands and in the feet, difficulty using the hands, trouble with walking. And until they actually develop those symptoms, we recommend they just continue to watch out for them. But once they do develop the symptoms, in that circumstance, we recommend surgery. But again, kind of like you mentioned, there are a lot of things that can cause these symptoms to occur. So for example, a stroke can cause you to feel off balance. Neuropathy can cause you to feel numbness and tingling in the hands and in the feet. Adverse reactions to chemotherapy agents can cause numbness and tingling. Arthritis in the hands can cause trouble using the hands. So it's just one of those things where, again, you have to sit down, talk to the patient, really kind of get a hold of what their specific symptoms are and why they are the way they are. So if someone says, oh, I have trouble feeding myself, well, why do they have trouble feeding themselves? Or if they say, oh, I have trouble walking, well, why do I have trouble walking? Is it because you have pain in the knee, pain in the back? Do you feel off balance when you walk? Do you feel dizzy when you walk? Do your feet hurt when you walk? Do you have numbness in your feet and the numbness in the feet prevents you from walking appropriately? Do you have foot drops? So there are a whole host of things that you kind of have to tease through. And that's part of the reason why, going back to part of our earlier conversation, part of the reason why I like spine, because you have to really get into the nitty gritty to kind of figure out what the person is experiencing, why they are experiencing what they are having, and trying to correlate that to the images that you see. So it's a bit of a detective work, but there's a lot of
problem solving in there.
Yeah, a lot of problem solving and a lot of interacting with the patients and their families. So it really brings together a lot of different aspects of medicine that I really like.
Yeah, well, no, I mean, it's very evident because I can hear as you're passionately talking about all this kind of stuff, and I can hear your enthusiasm, I can hear your engagement, I can hear all that come along through, and I'm sure all your patients feel that as well, which is a beautiful thing. So now, let's say a person comes in with a combination of these symptoms. I guess my real question, actually, as you were talking, was when you're talking about someone who has some kind of cord compression, but they picked it up because of whatever the circumstances of other symptoms that they have, but they don't have symptoms necessarily related to the cord compression. You tell a patient, oh, you don't have to do anything with this now, but they're worried. They might be someone who's like, oh, if it's something I can prevent or something I can stop the process of. Take me through how you kind of discuss with them at that moment, or is it something that you're saying, this may not necessarily progress beyond this point, or what, how does that look?
Yeah. This is a common conversation I have. So there are a couple points I would like to mention about this. So say, for example, someone had imaging done of their neck.
Right.
And the imaging shows spinal cord compression or shows arthritis that is about to cause spinal cord compression. And then we see the patient, we ask the patient those questions about the numbness and tingling in their hands and feet, trouble walking, trouble using their hands, and they say, everything is fine, no problem.
Mm-hmm.
And then they say, so what should we do? We have this imaging finding. I'm not having any symptoms. Should I have surgery for this? My advice to the patient is that they should wait until the symptoms occur. Once they occur, then they should call us, see us, and then we should potentially talk about surgery. So why is that? Okay, first of all, why do I say that we should wait?
Mm-hmm.
Okay. One part of it is that we don't know if and when they will need surgery. So some patients develop symptoms very rapidly, whereas others may not develop them for years and years and years. And because we don't really know the timeline, I am of the mindset that you should wait to let it actually present itself symptomatically. But once it does present itself symptomatically, and I'll get to this in a second, once it does present itself symptomatically, you should be more aggressive about then treating it. But because we don't know the timeline, who knows what the circumstances will be in 1 year or 5 years.
Mm-hmm.
And mind you, a lot of the patients who I'm talking to with this issue, some of them are in their 40s and 50s, but also a lot of them are in their 70s and 80s.
Right.
And circumstances may change in terms of their overall general health. The other part of it is, who knows over the course of that time what new technology may develop or what new understanding of this problem will develop. So one example is we do artificial discs in cervical spine surgery and also in lumbar spine surgery. That technology, those artificial discs, just came on the market within about 15 years ago. So who knows what other new technology or materials may be available that can help us better treat the problem surgically, or at least we can have a better understanding of the problem so that we can treat it more appropriately. Once you start to develop symptoms, though, then in those circumstances, we recommend surgery. The reason is because the purpose of surgery is to prevent the symptoms from getting worse. Okay.
So this is a good point that I'm hearing from you. And I guess the question I'm wondering is, let's say you have a vigilant patient, not one that you're worried about that's going to forget about whatever's going on. Mm-hmm. They develop symptoms as you're describing them right now, and they come back. What's the likelihood you operate and those symptoms, A, will go away, and if they had loss of like sensation or mobility, will they get it back or not?
If you look at the data, overall, the data suggests that in patients who have symptoms, and when you do surgery for this issue, that 2/3 of the patients get some improvement and 1/3 get no improvement. Okay. Mm-hmm. Now, the 2/3 that get some improvement, there's a big spectrum. Some get a little improvement, some get complete improvement. And there is a wide variety of patients. Some patients go several months with symptoms and progressive debilitation, and then they decide to have surgery.
Right.
Whereas others, once they start to experience any symptom, are very aggressive about having the surgery. But overall, 2/3 get some improvement, 1/3 do not. And that goes back to my original statement that the surgery is primarily for prevention of the symptoms from getting worse. You don't want the symptoms to progress anymore.
Right.
So because there are this group, this 1/3 who have no improvement, we want to do surgery earlier rather than later. Because if you happen to wait for someone to get more debilitating symptoms and they happen to be one of the 3 who don't get better, then they're left with debilitating symptoms. So you want to be somewhat aggressive about treating it early if you feel like someone is actually having symptoms related to the spinal cord compression.
Okay. So to that effect, to prevent that 1/3, what would be the downsides of saying, let's say I want to be an aggressive type, I don't have symptoms, but I do know incidentally or otherwise that now I have an area of my spinal cord that's tight?
Yeah. And I'll actually ask another question for you. Another question I get asked is, well, what if I get involved in a car accident, and I have severe stenosis or narrowing or compression of the spinal cord of my neck? I get in a car accident, and what is the chance of me getting a spinal cord injury?
Right.
So I get that question frequently. And my answer, to sort of reiterate what I said earlier, is we don't know the timeline. Like, we don't know if and when this will ever cause symptoms. It could be several years from now. The other part of it is, when we talk about surgery, even though the risk is very small, there is a risk of spinal cord injury related to surgery. Okay. All surgeries have risks related to it. We're obviously operating right by the spinal cord, and there is a very, very small risk related to spinal cord injury. How low is that risk? It's extremely low. How can I describe it for you? It's almost, because patients ask me all the time, well, what is the chance that I could get a spinal cord injury? And I tell them that I can never give a 100% guarantee about anything. But it's almost as if when someone drives home from work, there is no one that can look at that person and say, I guarantee you 100% you will make it home safely when you leave from work and go home.
Right.
And I say the same thing to the patient. There's no 100% I can guarantee that there will be no spinal cord injury, but the risk is that low, where like it's exceedingly low. But there's still a little bit of a risk.
It's a possibility, but not a probability.
Correct.
Yeah.
Then when we go back to risk of spinal cord injury and trauma, okay, and we look at someone who has arthritis in their neck and spinal cord compression, and we compare it to someone without that problem, and we put those two individuals and they're both in the same trauma, the person who has the arthritis in their neck does have a little bit of an increased risk of injury compared to someone without the arthritis in their neck. But the increase is still very small. It's not a huge increase. It may be twice as much, but overall, the probability may still be very low. It may be, instead of being 1%, it may be 2%. And when you account for that little increase in difference, and then take into account the risk of surgery and spinal cord injury related to surgery, that difference becomes even smaller then. So in that circumstance, again, it's not something that I recommend doing any surgery for just to prevent something down the road. You know, it's something where I would, again, be very mindful of the symptoms, keep a very close eye on them. And once you really start to feel like you're developing those symptoms, get back in touch with us, call us back as soon as possible, and then we will aggressively get it taken care of.
I'm sure that some of this changes too, depending on the patient on the other side that you have, where maybe they're not as reliable, or you're a bit worried about their life circumstance or whatever it might be, that you say, well, even though you don't have symptoms, you might say maybe it's better as a preventative measure to do it in this case, despite all those risks.
Yeah. And at least in that circumstance, I would schedule them to come back, in short-term follow-up.
Right.
I would keep in touch with them or have them come back rather than coming back in 6 months or a year. Maybe I would have that person come back in at least 3 months, so I can pay close attention to them and assess them myself and ask kind of these questions so that I can really make sure that they're not developing any issues or problems. But certainly the patient plays a huge role in the decision-making process.
So to kind of round everything out that you're talking about right now, give me your top things that you want people to be like, have in their minds, that if you are experiencing X, Y, or Z, you should come see someone like me.
I think the main things are symptoms related to spinal cord compression. So that relates to dysfunction in the hands, the constant numbness and tingling in the hands and the feet, difficulty with walking. And then beyond just issues related to spinal cord compression, you can have severe nerve compression that can also cause debilitating issues, particularly when it comes to bowel and bladder issues. So if you are unable to empty your bladder completely when you urinate, or if you're having accidents, whether they be from the urine or when you have bowel accidents, those are all very concerning symptoms that you need to be worked up for on a more urgent or sometimes at times emergent basis.
So basically, if you can't control your pee or you can't control your poop, that's, maybe those would be big red flags for you.
Yes. And again, not all the times are these related to spine-related issues. There are a lot of
for sure.
There are a lot of alternative causes for this. So, for example, constipation can cause even issues with urination.
That's right.
Urinary tract infections can cause issues with urination. Pelvic floor dysfunction can cause urinary incontinence and leakage of urine. Just getting older can cause bowel incontinence and urinary incontinence. So it's not to say that you need to be worried that you have a spine-related problem whenever you experience these issues, but it's still something worthwhile that you need to get checked up and worked up to make sure that there's not some bigger issue at play that's contributing.
Perfect. Well, this has been great. I'm just going to pause here for a second. How are we?
We're an hour.
Oh, wow. Okay. You ready to? Yeah. Yeah. No, I think that you're doing a great job, buddy. So that's good so far. All right, so I'm going to do a little bit of a wrap up. Well, this has been fantastic, Azeem. I must say, I can't thank you enough for being here, because I've learned a tremendous amount of what we can do to kind of prevent ourselves from, or not prevent, but at least mitigate some of the aging things that happen to us, as you were talking about when it comes to arthritis and whatnot. You did a phenomenal job of describing just the basic things that happen to every individual at every stage of life in relation to the spine, and how we need to kind of prepare and things we can do to kind of take care of ourselves. Don't smoke, which we say that to everybody. That's really important. I agree 1,000% with that for a variety of different reasons. Is there any other tidbit of knowledge that you want to leave us with before we part ways and say adieu for this time? Because I will definitely have you back.
No, I think this is a great opportunity and platform to provide some introduction into who we are, but also to provide some education to patients. And I think, like I said, that's ultimately what I see myself as in terms of a provider. I don't see myself as a surgeon or anything like that. I see myself as someone with a knowledge base that I would like to share with people, and I think there's a lot of misinformation and lack of education that's given to people when they are trying to figure out what's happening with them.
I agree.
And they get all these studies and all this information, and it can be very overwhelming to try to connect everything together. So I try to do my best to bring it into like a big picture so that people have some general idea as to what is going on with their health. So I think this platform serves as a good opportunity to do that to the general public. So it's been a good experience. I really enjoyed our time together. And definitely maybe when you bring Dr. Knuckles, we can do maybe a trio and have all three of us
I think
together.
that would be an awesome time. I think another thing that I'd love to have too is when you I know for a fact, because there's as you know, in this region and in others, the problems you deal with are very common. And a lot of people, a variety of ages, but particularly people who are older, experience them quite frequently. So I'm certain that this is going to generate a lot of questions, a lot of feedback that we'll have a nice moment for just even you and I, or you, me, and Russ to come back here and have a good Q&A session.
Yeah.
So. Well, that wraps up today's episode of the Intent Medical Group podcast. If you enjoyed this conversation, be sure to follow or subscribe so you never miss an episode. And if you're new to our podcast, welcome again. We're really glad you're here. You can learn more about our providers and services at intentmedicalgroup.com. And don't forget to connect with us on all our social platforms. We'd love to hear from you. Please comment, share, and like us on social media. Thanks again for listening. We'll see you next time.